I'm Erica McGough with Colorado Christian University, and this is my presentation for psychopathology on neurocognitive disorders with a focus on Parkinson's disease. So neurocognitive disorders, what are they? The DSM-5 says that they are disorders in which the primary clinical deficit is in cognitive function and that are acquired rather than developmental. There are various subtypes. I've listed several of them here. And all of these subtypes are similar in that they begin with delirium, followed by the syndromes of major neurocognitive disorder, mild neurocognitive disorder, and their etiological subtypes. So in actually diagnosing a neurocognitive disorder, there are criteria based upon 6 cognitive domains, and these are complex attention, executive function, learning and memory, language, perceptual motor, and social cognition. The categories of major or mild are used to differentiate between severity of symptoms. And the 6 cognitive domains, along with guidelines for clinical thresholds, form the basis on which these NCDs are diagnosed. And here at the bottom of the screen you can see a chart straight from the DSM-5, which gives an example of how major and mild executive function is diagnosed and the difference in the levels of severity. So neurocognitive disorder with a focus on Parkinson's disease. What is Parkinson's disease exactly? The National Parkinson Foundation provides a very concise definition. Parkinson's disease is a neurodegenerative brain disorder that progresses slowly in most people. Most people's symptoms take years to develop, and they live for years with the disease. How exactly is Parkinson's diagnosed? The DSM-5 gives us 4 diagnostic criteria. A, the criteria are met for major or mild neurocognitive disorder. B, the disturbance occurs in the setting of established Parkinson's disease. C, there is insidious onset and gradual progression of impairment. And D, the neurocognitive disorder is not attributable to another medical condition and is not better explained by another mental disorder. So, brain degeneration in Parkinson's, what exactly is happening there? Basically, in short, degeneration occurs because the brain slowly stops producing dopamine, which is a neurotransmitter. And as the level of dopamine decreases in the brain, a person's control of their movement, body, and emotion decreases as well. While it's known how degeneration occurs, it is not specifically known why or what actually causes the reduction of dopamine. Parkinson's is not fatal, but complications that arise from Parkinson's can be. Currently, complications from Parkinson's is the 14th leading cause of death in the United States. So this brain scan here is from Cedars-Sinai Hospital. The drug DAT scan is injected into the bloodstream and assesses neurons that contain dopamine. So here you can see the reduction in dopamine activity in the Parkinson's patient versus what normal levels of dopamine look like. And you can see far more dopamine activity. It's much more lit up on the other side of the screen. So treatment. Research is focusing on attempting to unlock the where and why of why the brain stops producing dopamine. And Parkinson's motor symptoms occur when approximately 60 to 80% of these dopamine-producing cells are damaged. This is where you see things such as tremors start occurring. So one of the current theories as to the where and why of Parkinson's is called Brack's hypothesis. In 2003, his research concluded that the earliest signs of Parkinson's are found in the enteric nervous system, the medulla in particular, the olfactory bulb, which controls your sense of smell. So under this theory, Parkinson's only progresses to the substantia nigra and cortex over the years. This theory is increasingly borne out by evidence that non-motor symptoms, such as the loss of sense of smell, hyposmia, sleep disorders, and constipation may precede the motor features of the disease by several years. However, this is just one theory, and it has received both support and criticism. Research continues trying to unlock the etiology of Parkinson's. Currently, there are really 2 main courses of treatment: medication and various types of automated stimulation. Medication. So for the purposes of this presentation, I'm going to talk about 2 very popular kinds of medication that are used to treat Parkinson's. The first is levodopa, or shortened L-DOPA. It's a very common and highly popular course of treatment because it directly affects dopamine levels in the brain. It's considered the gold standard. However, after long-term use, it does have negative side effects, most notably dyskinesias, which are the involuntary movements and motor complications, much like actual Parkinsonian tremors that arise after prolonged medication use. The next is donepezil. This is a CHI inhibitor, and it helps restore acetylcholinesterase in the brain. This enzyme is needed for nervous system functioning, but Parkinson's patients, that level is either broken down too quickly or there's not enough. So by using donepezil, it has been shown to improve cognition and neuropsychiatric impairment in Parkinson's sufferers. However, much like the use of L-DOPA, higher doses can actually increase Parkinson tremors. In 2014, there was a very small study done on patients currently on donepezil dose of 5 milligrams. They'd been on it for 3 months at least. And what they found is that these people who had been on a steady state of this donepezil, if they doubled the daily dose to 10 milligrams, they found an increase in mental state examination scores and an overall improvement in depression, anxiety, aberrant motor behavior, and hallucinations. So the study's findings suggested that donepezil is actually an individualized course of treatment, and that individual dosage and benefits greatly vary dependent on the actual patient. But those in a steady state and already on donepezil are good candidates for increased dosage. So in talking about medication, there are some major downfalls, most notably the need for frequent dosage. Remember that Parkinson's can occur over the span of decades. So when you factor in the need for daily dosage and the cost associated with that, that's a very big factor. Also, side effects are a very big downfall with medication. While there are benefits to medication, they're not necessarily permanent, and heavy medication use can lead to severe and detrimental effects, such as the previously noted dyskinesias. So next I'm going to talk about one type of automated stimulation, and that is deep brain stimulation. So what it is, it's a surgical procedure that treats Parkinson's, neurological symptoms such as tremor, rigidity, stiffness, slowed movement, and walking problems. What happens is a neurostimulator is surgically implanted, and this delivers targeted electronic stimulation to areas of the brain that control movement. And in doing so, it blocks the abnormal nerve signals that cause the disabling neurological symptoms you see in Parkinson's patients, such as tremor. They use MRIs and CT scans to pinpoint the exact point of the brain in which to put the electrode. And there are 3 main parts of the DBS syndrome, the DBS system. The lead, or the electrode, is a small wire that's actually inserted directly through the skull into the targeted area of the brain. And then the extension wire, which connects the lead to the neurostimulator, is taken down through the head, the neck, and the shoulders under the skin, where it's attached to the neurostimulator. So the neurostimulator is often put near the collarbone. It's about the size of a stopwatch, and it acts much like a pacemaker would. It sends electrical impulses up the extension wire to the lead and into the brain. So it's been found that when deep brain stimulation is used in conjunction with medication, the results are actually far more effective than medication alone. Long-term studies show that the benefits are maintained even after 10 years. So for long-term treatment of Parkinson's, DBS is very promising. And down here I have a link that actually shows the DBS system being turned on in a patient with Parkinson's, and you can see the tremors begin, and then as those impulses are starting to send up to the brain, the tremors actually completely cease. So we've talked about Parkinson's and the affected individual, but what about caregivers and families whose loved ones suffer from Parkinson's? As caregivers, we should not limit treatment solely to the individual with Parkinson's, but we should extend it to families and caregivers as well. In review, features associated with Parkinson's include apathy, depression, anxiety, hallucinations, delusions, personality changes, behavioral disturbances, sleep disorders, cognitive decline, motor function impairment, and tremors. All of these features can have a detrimental effect on the family and increase the stress and burden of caregiving. On the gravity of Parkinson's, one of his colleagues state, cognitive impairment, psychosis, and behavior disorders reduce patients' quality of life and increase caregiver burden. So when exploring what to actually do to help families and caregivers manage stress, Wilmoth and Smizer show how the ABCX model of family stress is used in order to help provide families with a framework to actually cope with stressful circumstances. And this can be used for an individual as well. It's very easily tailored. So A is the stressor event, whether internal or external, and is categorized as normative or non-normative, ambiguous or clear, and volitional or non-volitional. So after the stressor is defined, resources, B, are evaluated. And these can be on an individual or community level. They can be very collective. They include various categories such as intelligence, personal skills, an individual and family's health level, time management, flexibility, and then community resources as well. C is where the individual or family forms meanings based upon the stressor, the personal or family identity, and their worldview. X is the outcome. This plan can be adapted for use with an individual as well, as I previously stated. So in examining stress on families and caregivers, and those with Parkinson's as well, Philippians 4:6 reminds us that God is our ultimate resource. In times of stress and crisis, we can lift up our worries and anxieties to Him. And that's very important to remind ourselves and to help remind our clients as well. In conclusion, Parkinson's is a debilitating disease that affects not just those suffering, but their friends, families, and loved ones as well. As research continues and promising treatment develops, it is hopeful that one day we'll have a better understanding of the disease and eventually have a cure. Thank you.